السلام عليكم ورحمة الله وبركاته. إن شاء الله النهاردة هنكون في حلقة جديدة من محاضرات علاج طبيعي لأمراض العظام وإصاباتها. إن شاء الله هنتكلم النهاردة عن one of the most common diseases which is carpal tunnel syndrome. The objective of this lecture is that you will be able to define carpal tunnel syndrome, identify its causes and clinical features, describe the pathological changes, and learn how to examine a patient and establish a physical therapy program for such cases. The carpal tunnel syndrome is one of the most common focal peripheral neuropathies that affect human body. It results from compression of the median nerve at the level of the wrist, which is very particular to the carpal tunnel syndrome. As you all know, the median nerve could get compressed at different levels, for example, between the two heads of the pronator teres muscles. As you can see in this figure, you have here the transverse carpal ligament underneath the median nerve passes through its way at the wrist level to reach the fingers, the lateral 3.5 fingers, where it gives branches with a motor or sensory or autonomic. If the carpal ligament starts compressing on the nerve for any reason, carpal tunnel starts, and the compression will causes manifestation which we call the carpal tunnel syndrome. The causes of carpal tunnel are numerous. One of the most common causes of carpal tunnel syndrome is different anatomy, which means the carpal tunnel itself, which the bones and the flexor tendons. Anything that changes this anatomy so that the carpal tunnel volume decreases or the content increases might cause carpal tunnel syndrome. Another cause is infection or inflammatory conditions. Actually, the inflammatory condition, particularly inflammation of the leg flexor tendons, is one of the most common causes of carpal tunnel syndrome seen in patients who have work-related disorder. Another cause is metabolic conditions such as diabetes and hyperthyroidism, where fatty tissue starts to accumulate and cause compression on the nerve. The last thing is anything that will increase the water within this area, which is edema caused by pregnancy, by obesity, or any other water retention disease. The pathology of the carpal tunnel is totally dependent on the degree of compression. For example, acute compression by trauma will cause deforming force. This deforming force might change the mechanics of the carpal tunnel, causing deformation of this place. The room will change and subsequently the nerve will get compressed. Compression on the nerve will affect the blood supply to that nerve, causing ischemic changes, and hereby manifestation starts. Another cause is chronic compression. Actually, in chronic compression, the symptoms depend on the stage of compression. So let's start by saying we have 3 stages of compression. One patient might get a degree, might get 2 degrees, might go into the 3rd degree directly without with passing by one of that stages. This depends on the duration, upon the cause, and other multiple factors. In case of stage 1 chronic compression, there is a prolonged compression that interfere with venous return. Blood should come back from this area so that new blood could go. But in case of reduced venous return, there is a sluggish of circulation or slowdown of circulation, particularly in the epidural, which is the sheath surrounding the nerve, as well as the intrafunicular. This leads to increased pressure within the capillaries, and the blood supply is not adequate enough to provide the nutrition and wash out the waste product, results in nerve hypoxia or reduced blood supply to this region. If the condition continued, patient go into stage 2 of chronic compression. In this case, the most manifestation is related to severe sluggishness or slowness of the circulation, leading to hypoxia increasing into anoxia, which is no blood supply almost coming to the nerve, no blood, no nutrition, accumulation of waste products leads to damage of endoneurium with subsequent leakage of proteins and change of nutrients. This leads to reduced nutrition, increased fibroblast proliferation, and eventually leading to demyelination and axonal damage. And here we start in some irreversible changes within the nerve. If the patient is unlucky and the compression continued without seeking medical advice, there start Wallerian degeneration, which means retrograde degeneration of the nerve to the nearest node of Ranvier, and the nerve is no longer elastic tissue, but rather it's a fibrous cord-like or dead tissue. The clinical feature depends upon the degree of compression. However, we can summarize the clinical symptoms in few words. Pain, and this pain is unique by having the distribution on the medial nerve, which is from the palmar aspect, the lateral 3.5 fingers, and the tip of the lateral 3.5 fingers from the dorsum of the hand, or as you can see, the red coloration in the slide. There is also numbness, and the numbness in the same distribution as well as the tingling. Usually patients complain of pain, especially at the beginning at night, and that's why they call also the carpal tunnel syndrome the nocturnal pain syndrome, and this might awaken the patient to relieve the pressure on the hand, especially if the patient is leaning on a flexed hand. Patient always reports that he can feel relieved of the tingling sensation, pain and numbness with moving of the hand or shaking of the hand. Again, in this figure you can see the distribution of pain, tingling or paresthesia that might the patient come and complain. If the patient is complaining of something else, of the whole hand, it might be another dermatome or another something coming from the cervical spine. So please make sure that you know the exact distribution of the median nerve. The clinical feature of pain and paresthesia is confined to the wrist. However, it might radiate up to the forearm, even to the elbow or shoulder. There is association between pain of the carpal tunnel syndrome and numbness, as well as weakness of the hand grip. You know, the median nerve supply the entrancing muscles of the hand. So if there is a compression of the median nerve, there is a decrease in the grip strength and dexterity, as well as there is some motor symptoms in the or signs in the form of atrophy of the thenar muscles. I'd like to emphasize that most of the patients have bilateral symptoms or bilateral carpal tunnel syndrome. So again, this is something really important to recognize, because this could be an important differential diagnosis for cervical pain or radiculopathy. In this figure you can see the very clear atrophy in the thenar muscle. You can see here it's almost indented, or there is kind of a valley instead of the hill in this area. When you meet a patient with carpal tunnel syndrome, you need to confirm not only by history but by examination, and there are few things that can help you discriminating carpal tunnel syndrome from other differential diagnoses, such as cervical radiculopathy, such as Phelan maneuver, tunnel sign, and muscle testing, individual muscle testing, is particularly of thumb abduction, and sensory examination using the 2-point discrimination. I'm going to emphasize on the first two testing, which are Phelan test. Phelan test, you can simply ask the patient to put the two hands across each other and compress the median nerve. If the patient starts feeling pain along the distribution of the median nerve, then the test is positive and the patient has carpal tunnel syndrome. If the patient complains of pain in both sides for any reason, because of the extensor muscles are inflamed or tight, or any problem with the wrist, you can do it passively, and then you will ask the patient to extend the elbow and flex the fingers, and as well and flex the wrist and extend the fingers to make sure that you do the compression on the nerve. The second sign is tunnel sign. Tunnel sign is very useful sign when there is a neuroma in any region of the body. Simply you come at the compressed level and start tapping with your finger. If there is a positive sign, you will hear the patient complaining of pain, paresthesia or numbness among the distribution of the affected nerve, and in this case the median nerve. So to summarize the diagnosis of carpal tunnel, the diagnosis starts with history, physical examination for muscle weakness, tightness, as well as pain and paresthesia, and the absolute diagnosis could be done by using nerve conduction velocity, where you will find delayed nerve conduction among the palmar aspect of the hand. Differential diagnosis includes tenosynovitis of the flexor tendon, tendonitis, other diseases such as diabetes, which causes neuropathy, compression of the median nerve at the level of the elbow or even at the level of the brachial plexus. The treatment of carpal tunnel is divided into two big categories: conservative treatment and surgical. The conservative treatment is advisable to start with, such as in most of the diseases. I'm going to cover a few steps that you have to consider during establishing conservative treatment program. The first thing is general measures. Second thing is the rest splints, the use of rest splints. Third is the role of oral medication, physical therapy, and finally we are going to talk about the last conservative treatment option, which is local injection. For the general measurements, it is important to ask the patient to avoid any movement that will put compression or stretching on the median nerve, particularly repetitive movement of hand and wrist, such as in typing, hammering, or using of the hand in any manual work, because this will exacerbate the symptoms and cause repeated compression and distraction or traction injury on the nerve. Another thing is to avoid using vibratory tools such as digging tools, الحاجات اللي هي بيستخدموها عشان يحفروا الأرض مثلا. A third important general measure is to consider the use of ergonomically designed hand tools. For example, if a patient is going to use a keyboard, it's important to use rest pad to make sure that the rest is not flexed or extended, and hence the median nerve is not compressed or stretched. Here we have a few examples of ergonomically designed tools. On the left panel you can see a pin that is designed for patients who cannot or not allowed to grip or do compression on the median nerve by flexing the fingers and wrist. And as you can see in this finger, the patient doesn't need to oppose or flex the wrist and fingers, and this ultimately reduces the intercarpal pressure, which contributes to the pain in the area of the median nerve. In the other figure you can see a modified mouse pad and rest support, and the aim of this mouse pad and rest support is to allow resting position of the rest, in which the rest is neutral, neither flexed, neither extended, and the fingers are more relaxed with no need to flex the tendons or flex the finger, which again increases the intercarpal pressure and accentuates the pressure on the median nerve. The second important thing is splinting. Actually, splint play the most effective role, especially during the first 3 months within the start of the symptoms of carpal tunnel syndrome. The optimal splinting regimen is to put a splint that maintains the wrist and hand in a neutral position. Sometimes you might use a cook-up splint to rest the flexors tendons. The patient needs to use the splint especially at the beginning throughout the day. Then you have to gradually wean the patient from the splint by asking the patient to wear the splint when he is sleeping, especially if he has a habit to sleep on his flexed hand. The other time that the patient needs to wear the splint is when the patient is using his hand in vigorous movement, particularly movements that involve flexion of the wrist or hand, such as in carrying. The third important time to wear the splint is when the patient is repeatedly moving the wrist and the hand in flexion and extension movement. As you can see here, during computer use or keyboard typing, there is repeated flexion extension of the fingers, and splint use will be advocated at this time. On the left panel here you can see the splint, the neutral carpal tunnel splint from the dorsal aspect. Doesn't do anything except maintaining the rest. It has nothing to do with the finger position. If conservative treatment in the form of physical of splinting doesn't work, then the second step is usually oral medication prescribed by the physician. Usually these medication include non-steroidal anti-inflammatory, vitamin B6 or vitamin B complex, which improves the overall health of the nervous tissue, diuretics in case of edema, and sometimes patient might need orally administered corticosteroids, especially when it is inflammatory condition. Physical therapy plays an important role. If the oral modification and splinting doesn't give adequate response within 2 weeks to 7 weeks, then physical therapy is the choice, and the choice is between two things: is ultrasound, and it's usually preferred to apply ultrasound with underwater technique because of the irregularity of the hand. You might use ultrasound in a phonophoresis mode by applying anti-inflammatory medication on the top of the gel you are using for the ultrasound waves. The other thing is the use of cold packs might help, but please make sure that you that your patient have normal sensation. Otherwise you might cause frost burning. You know, cold can cause burning, especially if it is prolonged than 20 minutes, or increase edema by rebounding edema after vasoconstriction. There is always vasodilatation when the cold application exceeds 20 minutes. The other thing you can ask the patient to do is to do what is the so-called tendon gliding exercise. Tendon gliding exercise aim is to maintain the flexibility and the sliding movement of the flexor digitorum superficialis and flexor digitorum profundus. You ask the patient to put his hand as a straight fist, then to make a hook fist, which is the action of the flexor digitorum profundus. Then you ask the patient to extend the fingers once more and start with a straight fist in which the metacarpophalangeal and the proximal interphalangeal is flexed 90 degrees. You might combine the two if the patient is pain-free and ask the patient to hook and then straight fist his hand. The repetition is within patient tolerance, but usually it is done at least 3 times a day. Each time is 3 bouts with 10 repetition in each. Again, the aim is just to minimize adhesions, and this is advocated when the patient has tenosynovitis in the long flexors. I'd like to emphasize that, you know, in physical therapy we are trying to move into evidence-based practice, and the evidence-based practice says that oral medications, splinting and ultrasound are effective. However, there is recommendations that we should consider other modalities because there is nothing against or with it. It might need further research, but you need to know that something like activity modification, acupuncture, laser, exercise, electrical stimulation, ionophoresis and phonophoresis, massage therapy and manipulation could be alternative that are that might improve the patient or not. So these are the second level of intervention after splinting and physical therapy in the form of ultrasound. If the conservative treatment failed with oral medication, splinting and physical therapy approach, then probably the patient need to be referred back to the surgeon or orthopedist to decide what is the next step. And the usual next step before surgery, considering surgery, is local injection using cortisone, and this also causes improvement in most of the cases. However, not every patient responds in the same way. So some of the patients might not respond to the conservative treatment or the invasive treatment in the form of local injection, and then surgery is the only option at this point. Otherwise, the patient condition is going to get progressive, and the irreversible changes will predominate, and thus the patient will lose some of the function and sensation of the hand, which is important for daily function. So in this table below, you can see the average time or minimum time actually that you can expect some improvement in patient condition. So if the patient is treated with local steroid injection alone, splinting alone or oral steroids, you expect at least 2 weeks before the patient shows signs of improvement. If the patient is treated by ultrasound, you expect 7 weeks to pass before you see some alternative. It is recommended to wait for the patient before moving from one stage to another. For example, before moving from splinting to oral medication, from oral medication to physical therapy, from physical therapy to local injection, you need to wait for 2 weeks to 7 weeks until you really make sure that it is the time to move to the next stage. After trying all other alternative and conservative alternative, the only option would be surgery, as I said before. Early surgery is usually not the case except in patients who came with signs of median nerve denervation, which means the patient is progressive and there is no way to stop it. So this is the only case, and this usually happens with acute trauma. Otherwise, it is again the conservative treatment that predominates before surgical intervention. In the surgical interventions, there are different surgery. It could be done open or closed, and the whole idea is to start releasing the carpal nerve, the median nerve, from underneath the transverse carpal ligament. It is recommended that if the patient has tight transverse carpal ligaments, that this ligament should be dissected, divided, and the tendons as well as the nerve are released. If there is any other causes of carpal tunnel, such as dislocation of the lunate bone, surgical fixation and reduction should take place. After surgery, physical therapy is usually recommended, although there is no evidence against or with the use of physical therapy in this period, but it is expected that using physical therapy could delay some of the expected complication after surgery. Let us divide the physical therapy approach after surgical intervention into 3 stages. The first stage starts from week 1 till the end of the 3rd week. The second stage starts from the 4th week till the 12th week, and the last stage is after 12 weeks of having the operation done. The goals during the first stage is to control edema, post-operative edema, maintenance of range of motion, active and passive, restriction of adhesion formation, which is common after any surgical intervention, and allow protected use of the hand. These goals could be achieved by different methods. For example, for the edema, constant elevation, and we have here to elevate the arm before the level of the heart. So you might ask the patient to put the hand over his head and start moving the hand to pump the fluid back and thus reduce edema. Also, you might apply retrograde massage, which means massage from distal to proximal, and this is the way the massage is usually done, is by squeezing or milking the fluid back to the heart by pressing in one direction, then return back to the starting position without any pressure. Again, press and release. The other thing is tendon glide, and again the aim is the same like in conservative treatment, which is that to prevent the adhesion between flexor digitorum profundus and flexor digitorum superficialis, especially where they cross each other at the level of the middle phalanx of the hand. And again, the tendon glide is by asking the patient to start from the neutral position of rest, neutral finger extension and phalangeal extension. Ask the patient to do a hook grip to move the flexor digitorum profundus. Then ask the patient to extend and do a straight grip. Then ask the patient to return to the starting position and start doing both together. You might ask the patient to do exercise for the shoulder and the elbow, although they are not directly affected. However, if the patient is putting his hand is blunt, not using his hand, it is edematous, then probably the movement of the whole upper limb is affected, and helping the patient to move the arm will help the hand to start taking the regular positions and help to pump back the edema fluid. After 1 week, Usually patient it changes the polar cast, which is the plaster cast or splint applied after surgery, and replace it by a thermoplastic splint, which allow removal and application, and hence we can start weaning the patient from the splint use gradually. By this we ended the first stage of post-surgical management. The second stage starts again by the end of the third week or the start of the fourth week till the 8th week, and during this period you want to continue reducing the edema if there is any persistent edema. If there is a scar, especially in case of open surgical intervention, you want to modify the scar and prevent the formation of keloid or the adhesion between the released nerve and the scar. Reduce the hypersensitivities that might be associated with such cases in which the patient complains of severe pain or increased sensation of normally felt textures. You want to increase the strength of the hand, especially of the small hand or thinner muscles and the wrist flexor and tendon flexors. You want to make sure that the active and passive range of motion are normal or within normal. To achieve these goals, again, you might ask the patient to do overhead bilateral fisting, which is kind of circulatory exercise from an elevated position, help pumping the fluid and increase the range of motion. You might continue applying the retrograde massage with deeper pressure as such case is a chronic and you are no longer afraid of skin irritation. For scar modification, you might apply elastomers, which are adhesive garments applied, and it exerts some kind of pressure on the scar. This pressure subsequently causes kind of pressure that remodels the collagen fibers. You know, collagen fibers are usually randomly oriented within the scar tissue, so it becomes more flattened and have a better cosmetic appearance. The other thing is continuous pressure applied by the elastomers help to reduce the blood supply to this area, and thus it's kind of producing ischemia to the scar, and thus the proliferation of the scar stops and shrinking of the scar starts. The third thing is use the desensitization program to decrease hypersensitivity. The idea of desensitization program is that you have a patient who complains of increased sensation and you need the nervous system to get accommodated to this increased sensation. So we start subject the patient to different textures and different sizes of materials and ask the patient to try to touch these textures. We might use a brush and surround the fabric on it or tie the fabric on it and start moving or rolling the fabric on the hand. You usually start with what the patient can tolerate, but with discomfort, and then continue to progress to more tough or rough tissues. For example, you might start with mousseline, which is kind of silk, and progress towards the Velcro, which you use for your sport shoes. To increase the strength and again the active range of motion, you might start isometric and isotonic exercise for the wrist and the hand. For example, if you want to resist the flexion of the wrist, you start flexing the fingers against resistance. You might put your hand and ask the patient to open the fingers. You might put the fingers like that and ask the patient to adduct the fingers. You might try to train the grip by asking the patient to hold an object on his other hand and start pulling. You can also use other instruments such as elastic balls or sponges and so on. Finally, you might apply the so-called nerve glide. The idea of nerve glide is to continue the elasticity of the median nerve and make sure that there is no adhesion surrounding the sheath or restricting the movement of the median nerve. The median nerve glides have six stages. You start by asking the patient to beat the arm in abduction, and then start with the wrist in neutral and finger flexed. You ask the patient to start extending the fingers. The idea is that you need to stretch the nerve, yet the patient doesn't need to feel any numbness or paresthesia, just discomfort. So you start by putting the finger in neutral position, and extending the fingers and thumb. If the patient is not complaining of paresthesia or increased pain along the distribution of the median nerve, you start asking the patient to extend the fingers while the thumb is adducted. Then if there is no complaint, you start progressing into thumb abduction. If there is no complaint, you start asking the patient to supinate the arm. Finally, if there is no complaint, you ask the patient to stretch on the web side or the web space of the between the first and second finger. Again, you start where the patient feels discomfort, no pain, no paresthesia. You continue as the patient can tolerate. You might take 1 week to progress through the whole cycle. You might take 1 month. It depends on the patient, and the only decision the only sign that can make you decide to progress or to stay in the same stage is the pain and the paresthesia along the distribution of the median nerve. After 12 weeks, technically, the patient is good to go. Which means the patient can start light activity such as house repair, cleaning, some slight housework or writing or typing using the splint or without a splint. You might start heavy demanding activity, for example, activities that requires repeated wrist flexion extension, especially if it is combined with finger flexion. Patients with sedentary lifestyle, like a patient who usually type, or patient who just like secretary, just write, might go back to full job with no pain, no problem within 8 to 10 weeks. However, physically demanding jobs need further attention, and you usually need to examine the patient by using the so-called work tolerance program. In this, the aim of this work tolerance program is to see whether the patient is able to return back to the heavy duty like digging or using vibratory machines. And in this case, you evaluate if the patient, while he is performing repeated movement or exercise that simulates the job. For example, if he uses vibratory machine, you bring the patient some kind of vibratory machine and ask the patient to apply what he used to do, or put the hand in the regular position he used for his work, and start seeing whether swelling or symptoms start appearing again. If it starts to reappear again, then you ask the patient to continue the conservative treatment and take additional 4 weeks of physical therapy before returning back to work. If not, the patient is good to go. Some cases, especially patients who had a history of chronic compression for years, might still by this stage complain of some residual pain, and in this case you might try to control the pain using electrotherapy in the form of high voltage galvanic stimulation and transcutaneous neuromuscular stimulation, which compete with pain signals at the level of the gates of pain. You might also consider using contrast paths, which is very nice approach for all peripheral pains, whether the hand or the foot. And the contrast path, from its name, you have to contrast medium, hot water and cold water. You ask the patient to put their hand in cool water for 30 seconds and then warm water in for 30 seconds, and repeat the movement between the two paths until for 15 to 30 minutes. Another alternative to reduce pain after prolonged pain after surgical intervention is the use of phonophoresis, which is ultrasound, again using medium gel and or anti-inflammatory gels such as Ripril, for example. By this I came to the end of these lectures, and I'd like to summarize or sum up what we have talked about today. So today we talked about carpal tunnel syndrome, which is the most common focal peripheral neuropathy, and we talked about the common signs and symptoms, which is basically pain and paresthesia. in the distribution of the median nerve, which is the lateral 3.5 fingers from the palmar and the tip of those fingers from the dorsal aspect. And we talked that these symptoms could be controlled by first using splinting, second using oral anti-inflammatory, third by physical therapy, fourth by injection. And we need to give the patient 2 to 7 weeks before trying the next step in each of these. If no conservative treatment helped, then surgical intervention is the only option, and surgical intervention is usually done in the form of complete release of the nerve, either by open or endoscopic carpal tunnel release. The second part of this lecture will be Duchenne disease. Duchenne disease is one of the most common diseases that affect the tendons of the hand. It basically affects the abductor pollicis longus and extensor pollicis brevis, which are the first or lateral border of the anatomical snuff box. As you can see, we have here a space. In this space, the first compartment of the rest tendons pass, then the third compartment of the rest pass, which is the extensor pollicis longus. Duchenne disease basically affects this region, and when the patient complain, he usually have a history that is related to repeated movement of the wrist and hand, especially manual working. So patient who hammer or who use drive screws usually complain of pain in this region. The patient might also have history of practicing lifting of objects, heavy objects, like for example a patient went for shopping and she bought some stuff, so she came home with pain in this region. So usually the history starts either with the occupation or a particular heavy demanding movement. The pathology is basically tenosynovitis, which means patients have inflammation in this area. So you might see some swelling in this area. The patient might have some tenderness in this region. When the tendon becomes inflamed, it becomes flattened and thinned and covered with granulation tissue, which reduces the elasticity or the mobility of the tendon. And as the fibrous sheaths become further inflamed and edematous, the tendon movement is constricted at this area. So basically, the stretching movement of this tendon, which is ulnar deviation, is difficult for such patients. A sequelae of this change is loss or reduced blood flow, which might affect the nutrition and the ability of the tendon to self-repair using the blood supply that comes to the area. The major symptom and very diagnostic symptom for this patient is discomfort at the radial aspect of the wrist, which may radiate proximally to the forearm or distally into the thumb. The pain has a character of being aggravated or increased by either stretching or by thumb and wrist movement, whether active or resistive extension or abduction of the thumb. To evaluate the patient, you have to start with history taking, observation, palpation, and then special testing. For history taking, as I said before, the patient usually have a history, a positive history of occupation related or physically demanding movement that is related or has led to the disease. On observation, you might see the patient splinting his thumb against the fingers or splinting the whole wrist and finger by the other hand. For the palpation, once you put your hand under at the radial aspect of the wrist, the patient usually complain of tenderness. You might be able to roll the tendon, the inflamed tendon, under your fingers and see patient response to this movement, which is usually apprehension or pain. To confirm the diagnosis of Duchenne disease, you ask the patient to put his both arms in elbow extension and tuck the thumb in, flex the fingers and ulnar deviate the wrist and hand. When the patient performs this movement, he usually confirms the pain at the radial aspect of the wrist, and it might be shooting as well to the forearm and thumb, as we mentioned before. You might need to confirm the edema that the patient has by using the volumeter, which is a jar full of fluid, and then you start putting your hand, and the displacement of water reflect the amount of edema in comparison to the sound or normal side. You might also use measuring tape to measure the contour of the finger, especially the thumb finger. If the patient pain is severe, you might want to use a visual analog scale, which ranges from 0 to 1, and ask the patient to rate his pain at the area when you are palpating, and in relation to the time of the day, activity, or you might ask the patient to report the duration of pain he feels after performing certain activities. And you also might see the posture of the upper extremity, like crest flexion, ulnar deviation, extension, that increased or decreased pain. Some patients, especially who need the strength of their hand, like who work in dangerous occupation that require strong grip, you might need to test their grip strength using handheld dynamometer, which is a machine that shows the amount of hand pressure using a dial. The treatment of de-Quervain disease is usually conservative, and the basic idea is to give rest for the inflamed tendon, which again are the abductor pollicis longus and the extensor pollicis brevis, and this usually is done by using thumb spica, or putting the thumb in a splint in slight degree of abduction, flexion and opposition, and maintaining the wrist at neutral position. We usually use prefabricated or fabricate custom-made thermoplastic material. With the splint worn by the patient might be instructed to move the fingers using the tendon glide we described in carpal tunnel. You might also start asking the patient to do active range of motion, passive and rest movement of the wrist. Patient usually wears the splint for prolonged period at the beginning, but later he starts to wean himself from the splint, and during the weaning period you start the active rest motion. Sometimes, if the patient pain is persistent, local injection of steroids in the first dorsal compartment might solve the problem. Otherwise, conservative treatment in the form of exercise should be enough, and we usually ask the patient to do some kind of exercise in the form of creeping or folding towels or sheets, bed sheets. We also try to continue the exercise for a short period to prevent overuse by applying the exercise for 10 to 20 minutes. And if the patient starts showing tolerance to the exercise, then we can progress to include other exercise and prolong the duration of exercise. We also need to monitor the edema that is usually persistent during the first few weeks, and to control the edema, the best way is to ask the patient to elevate the arm above the wrist, the level of the heart, and start pumping action. You might also try to apply a compressive stockinette or compressive garment to prevent the development of edema or help resolving edema. Please be advised that edema with the use of splinting usually increases because of the lack of movement, so you need to make sure that your patient, even if he is inside a splint, that he always move his fingers, elevate his hand or arm above the level of the heart, so you can reduce the formation of more edema and get rid of the already available edema. Other alternatives that can help control the edema include retrograde massage that we talked about in carpal tunnel syndrome, the use of ice pack that reduces edema for 10 to 15 minutes. Make sure that you are away from the radial styloid process, which is a prominent bony prominence and is not covered with fat tissue. So this might cause cold burn. Also, to reduce edema, you might use contrast bath, which is basically exercise for the vessels, which causes repeated vasoconstriction and vasodilatation, which help to improve the venous return. You might also use phonophoresis with ultrasound to increase the absorption of the medications. And you might use hydrocortisone, which is a strong anti-inflammatory, to get rid of the excess edema and inflammation. After the acute stage, which lasts for the first 4 weeks, we usually go into the second period, which lasts for another 8 weeks or till the 12th week. And during this period, if edema is still persistent, pain is still persistent, then we have to have an active treatment in the form of activity. Also, splinting should be gradually weaned from the patient, and patient should only wear the splint during heavy demanding movement, especially when the patient starts doing the movement that stretches the finger or resists finger abduction and extension. Thumb protection is advocated at this period, and thumb protection can be done by asking the patient to splint the thumb against the hand, by avoiding repeated flexion, extension, abduction of the thumb, and avoidance of tucking the thumb inside the wrist. Also, patient need to start his activity of daily living. However, patient should review what activity he does and what activity he or she might think it is related to the disease. For example, if the patient have a particular way of writing, it might be the cause of the disease, then patient need to start modifying this activity. If the patient has a habit of putting the finger inside the hand, even like when resting his, for example, during rest, then you need to start with the patient figuring this out so you can get rid of this position gradually and prevent recurrence of the disease. During the second phase, as we continue to control edema, we continue to improve the range, we also need to improve the strength of the muscles of the thumb, and this can be done by isometric exercise. You ask the patient to put a tube or a rod in a dough or something like salsal and start doing exercise. For example, by putting the finger in this position, you are resisting finger abduction, thumb abduction. By doing this movement, you are resisting finger or thumb flexion, and opposition. By doing this movement, you are resisting thumb adduction. This isometric movement will help improve the symptoms, yet it will not cause pain or increase the demand on the finger. As the patient pain improves, you start going into different type of exercise. So instead of isometric, you can move into isotonic. So for example, you might ask the patient to hold a pen and start flexing, or start adducting, or start extending, and so on. You also might start doing exercise for the wrist in the form of isometric strengthening for the wrist muscles, isotonic using weights, using TheraBands, and even if the patient has a heavy demanding job that imposes stress or load on the thumb, you might start work simulation. And by work simulation, we mean you start putting a workstation that has tools of the same size, same shape, and progressive weight, and you start putting a program or planning a program for your patient to use these tools as he usually does or she usually does at workplace. However, with progressively increasing the range, progressively increasing the weight and the duration. This will help you to decide when the patient is capable of returning back to his job. In these figures, you can see here the work simulation station, and in the work simulation station, you start taking from the patient history to see if the instruments are available, or you can start prescribing the instrument that can be used as an alternative or modification for the workplace station. In this period, the second phase again, patient can initiate short period of rest and thumb movement to the mid-range, and he can start to go back to work. However, it is recommended to start gradual working, which means the patient, if the patient needs to work 7 hours in a row, you will advise the patient to start with 2 hours or 3 hours. Then you might start 2 hours, then taking a break, then another 2 hours, and so on. And by decreasing the period of break and increasing the work duration, you are bringing the patient back to his routine life with no hazards of having complications or recurrence. During this period, of course, the patient is no longer allowed to use the regular thumb spica, removable thumb spica. Instead, a flexible support might be used, and the aim of this flexible support is just to make sure that the patient is not going to put his hand at risk. Just a reminder, nothing more. If the patient responds to physical therapy and work simulation is not good enough, then you might start thinking about the alternative, and the alternative is surgical approach. So when the patient can have surgery, usually when there is no improvement in symptoms after initial treatment, and that continued for 3 to 6 weeks. So if the patient continued treatment and there is no sign of improvement, then after 6 weeks you have to return the patient back to the surgeon or treating physician and ask the patient to see whether he needs decompression of the inflamed tendon or not. By this, I have discussed today with you decurvent disease, which is inflammation of the abductor pollicis longus and extensor pollicis brevis, and which is usually work-related or related to a particular movement of the thumb. And we emphasize that the treatment is basically based on patient problems, which are edema, pain, inflammation, and weakness of the muscles. I enjoyed being with you in this lecture. Today we discussed carpal tunnel and decurvent disease. Good luck in your study, and all the best. Thank you.